A 50-year-old male presented
Hmm.
to our OPD with a chief complaint of swelling in the right gluteal region since 5 months. Patient was apparently all right 5 months
So
back.
he will not say gluteal region because history is in the terms of the patient, in the right buttock.
Right buttock region since 5 months. Patient was apparently all right 5 months back. To start with, he noticed a small swelling in the right gluteal region, which is insidious in onset, initially small in size, which gradually increased in size, but for last 2 months, there is a rapid growth to attain the present size and not associated with pain.
So you have to tell how small was the lesion to start with.
It's around the ma'am when he noticed that it's small about the tennis ball.
Tennis ball
Yeah.
is quite big. Tennis ball is quite big.
But at present the swelling is around 10 into 10 centimeter now.
Tennis ball is approximately 5 centimeters diameter.
Yes,
So he noticed the lump and it was about
yes,
5
ma'am.
centimeters.
Yes, ma'am.
And now when you say it's the present size, we don't know what present size is. So what
Yes,
is the approximate size
10
now?
into 10 centimeter.
Okay, so you can say it has increased to twice that size.
Yes. And there
ठीक
is
है.
no history of trauma, fever, pain, weakness of the right lower limb, tingling numbness in the right lower limb, weight loss or loss of appetite, backache, cough, dyspnea, chest pain, hemoptysis, and no abdominal and genital symptoms. There is no history of radiation exposure, no comorbidities. Personality is not contributory. Only the thing is history of tobacco use is 30 years, 5 to 6 times daily, small amount. Family history and drug history is not contributory. General examination, patient was well oriented for time, place, and person. BP is 118 by 80 mmHg measured in right upper limb, supine position. Respirator is 16, pulse is 82 per minute. Pilar is present but no icterus. There is no pilar is present but no icterus, clubbing, sinuses, edema, no generalized or supraclavian lymphadenopathy. On inspection of bilateral gluteal region and lower limb, the gait of the patient is normal. Range of motion of hip joint is equal on both sides. No limb length discrepancy, no pedal edema. Left gluteal region is normal. But in right gluteal region, a visible swelling of size 10 into 10 centimeters situated centrally in the right gluteal region, that is 3 centimeter below the iliac crest, 2 centimeter lateral to the gluteal cleft, 3 centimeter above the inferior gluteal floor, and 5 centimeter from the ASIS. Spherical in shape. Surface is smooth. All margins is well defined. Skin or the swelling appear normal with no dilated veins, ulceration, no sinuses or scars.
In what position did you examine the patient?
Initially, sir, prone position.
Did you look at how the patient sits on a chair?
Yes, sir. He sits normally, sir.
It sits normally.
Yes.
10 centimeter
Patient,
mass and he sits normally.
yes, sir. Because patient came with in the our OPD with driving the two-wheeler, sir, itself. Sir.
Still, he will not be sitting normally if you have a 10 centimeter lump on one of your buttocks. You will adjust your posture. Try putting a mallet under your buttock and sit. You will be able to sit, but you will have to balance. The posture is going to change. The spine is going to tilt. I don't see examination in sitting position. You have to see the compensation, that how is he compensating. He may be sitting, he may be looking like sitting comfortably. But until unless you ask him to take off his shirt and look at his spine, that how is he balancing? How would he be balancing?
The upper portion of the spine should be straight and the spine should be curved towards the opposite sides. The body is tilted towards the same side.
Which side he will be compensating? Normal side or abnormal side?
Abnormal sides.
He'll be compensating from the normal side. So he has to raise the normal. So the curvature will be towards the disease side.
Patient temperature was normal. There is no tenderness. A 10 into 10 centimeter mass in the right gluteal region, centrally placed, globular in shape. All border well defined or were well defined. That is superiorly 4 centimeter below the iliac crest, inferiorly 3 centimeter above the axial tuberosity, medially 3 centimeter lateral to the border of sacrum, and laterally 2 centimeter middle to the greater trochanter. Form in consistency, a smooth surface. The swelling.
This greater trochanter, how do you locate it?
Ma'am, it is a projection in the lateral aspect of the thigh.
No,
The
there
mid
is a
body
surface
prominence.
landmark. So there is a landmark for greater trochanter. So you read it, how exactly to find the greater trochanter.
The swelling is firm in consistency, a smooth surface. When the hip is relaxed, knee is when the hip is released, the swelling is
And
quite
on
mobile.
inspection, you said it's a spherical swelling. Is it possible to say spherical swelling here? Spherical swelling, can they say? Spherical is like in 3 dimension, you can roll it like a ball, tennis ball virtually. And here it says globular in shape, globular shaped organ that we commonly
It's
say.
just three dimensions set, ma'am. Swelling is forming consistency, a smooth surface. When the hip is relaxed, the swelling is quite mobile, but restricted mobility when when the right thigh is extended and abducted in the direction of muscle, that is gluteus maximus muscle, and skin or the swelling is pinchable, no inguinal limb, not palpable. On neurovascular examination, no muscle wasting, limb movement normal at hip joint, muscle power and tone normal, distal pulses normal, all femoral, popliteal, anterior, posterior, and dorsalis pedis, no sensory loss, and deep tendon reflexes preserved. The on systemic examination within normal limit. On summary, a male patient aged 50 years presented with a right gluteal mass since 5 months with a rapid growth of swelling since last 2 months, which is firm consistency, a smooth surface, well-defined margin. Mass is mobile when thighs relaxed and restricted mobility when thighs abducted and extended. No clinical neurovascular involvement with no inguinal lymphadenopathy. My above finding, my diagnosis is the malignant right gluteal mass.
So what are the features that suggest it is malignant?
It is short history with a rapid growth since last 2 months.
Other than rapid growth,
Any
Uh,
significant
and
negative history?
There is no history of radiation in the past, ma'am.
Radiation? How do you link radiation here? Thinking of?
Radiation is one of the yes, sir.
what are the common causes of a rapid increase in size of any swelling?
Sir, there is a hemorrhage inside the swelling, malignant transformation, necrosis inside swelling, sir.
Necrosis inside the swelling. So with three causes you have given me, why do you think it is malignant transformation?
Sir, because hemorrhage and necrosis will lead to the pain in the swelling, sir. But patient did not complain any pain.
What is the cause of necrosis in a swelling?
It is due to hypoxia, sir, mainly hypoxia. When the swelling is
So
rapidly
why
growing,
it will cause pain?
So this necrosis can occur only in a malignant mass, or it can occur otherwise also?
occur in benign also, ma'am, when the growth is
No, there is no tumor. There is no
yes, ma'am.
tumor. Can there be a necrosis? Haven't you heard of traumatic necrosis, fat
Yes, ma'am.
necrosis?
But patient didn't complain of any history of trauma, ma'am.
That's all right. Here we are discussing in general. So
Yes, ma'am.
necrosis
Yes,
can
ma'am.
happen, and
Yes,
it's
ma'am.
one of the commonest causes of pseudo lump here, presenting in the gluteal region or in the breast also.
So basically, other than a rapid increase in size, you have no features that suggest that there is a malignant mass. Such a situation, it is much better to say that it is a soft tissue tumor because you don't know the nature of the mass.
Yes, sir.
You cannot elicit it by your history and examination in this particular case.
Sir, I will go for first imaging of the patient. And patient came with our OPD with a MRI film, sir. Sir, this is the T2 weighted image of the MRI film. T2 weighted image of MRI film. In this film, sir, the three muscles, this one is the gluteus maximus muscle. This is gluteus medius, and this is gluteus minimus of the right side, and this of the left side. The mass is mainly arising from the right gluteus maximus muscle with a solid and cystic component, mainly cystic component with a solid area.
So where is the mass seen to be arising? Mass seen to be pushing the gluteus maximus inside.
Yes, sir. But this mass arising from the gluteus maximus, sir, and pushing the gluteus medius and minimus inside.
I can see a plane between the gluteus maximus and the mass. You see a black line between the gluteus maximus and the mass?
Yes, yes. Move your arrow a little laterally.
This one, sir.
No,
No,
no.
between gluteus maximus and the mass.
Or picha. This.
That's exactly. You
Yeah,
see
yeah, yeah.
line
Yes,
there?
sir. Hold it. Yes.
There is a clear plane between the muscle and the mass.
This is also a part of mass, sir, actually.
Yeah, that is your mass starting. Okay, go down. So you have a bilobed mass, and the consistency and the content
Is
of both lobes is different.
yes, but
So what
cystic content is mainly the content is mainly inside, and the solid content is outside the superficial sides. This swelling is pushes the gluteus medius and minimus inside, but there is no infiltration. Also, this neurovascular structures is also not involved in the this tumor. Sir. And this black is the sciatic tumor.
Okay. So from
So,
this MRI, what can you tell? What kind of a
it
tumor?
is a complex mass, sir, which has a solid and cystic component
Okay.
arising from the gluteus maximus muscle.
Okay.
The flat plane preserved with gluteus medius and minimus muscle with no neurovascular involvement. Sir.
Okay. So what are the kind of mixed tumors which arise from muscle?
It is a myxoid liposarcoma, sir. Fibromyxosarcoma, myxoid liposarcoma.
You said mass
San-
is arising from gluteus muscle.
Yes, sir.
So how do you explain a lipomatous tumor arising from a muscle? I tried to save you by telling you that there is a plane between muscle and the mass.
Yes, sir.
But you insist that it is arising from the muscle. So now tell me, how does a
Sony,
lipomatous tissue?
please, you answer that and also show me the gluteus maximus once again, please.
Yes, ma'am.
Keep your arrow on the maximus.
It is pushed downwards. The mass actually is
I
between the
also think,
medius,
This is
maximus and medius.
yes.
It is
It
lying
is
between the two muscles.
splitting. Yes, it is splitting the two muscle, two facial planes also. दिखाओ धीरे धीरे करो.
Maximus is seen below the mass, thinned out,
Yes,
thinned out.
yes,
this
I
sir,
agree. No, नीचे.
this one.
You compare it with your opposite
नीचे
side.
नीचे नीचे हाँ ये
ये
Yes.
देखो, see the other side also, and you can appreciate that. You can see that facial plane, no, that thick facial sheath between the two, medius and maximus. हाँ, इधर compress हो गई है वो. Yeah, see the other side. It's completely outside this. It looks like. I mean, it's outside.
What are the tumors that arise from the muscles, skeletal muscles? If you say this is arising from gluteus maximus, could not be a lipomatous tumor.
Yes.
Lipomatous tumors always arise between the two muscle planes or in the subcutaneous plane. So what are the tumors which arise from the gluteus muscle, from a skeletal muscle?
There is a rhabdomyoma, either rhabdomyosarcoma, and malignant fibrous histiocytoma.
That term is no more used.
That is a undifferentiated pleomorphic sarcoma,
Yes.
and synovial sarcoma. Sometimes synovial sarcoma arises from the muscle fascia.
See, what is the reason for doing a MRI in this patient?
Sir, first characterization of the mass first.
Hmm.
Also to look the surrounding structures
Hmm.
and the place between the surrounding structures from the status of neurovascular status and whether this tumor is operable with a good margin or not.
Okay. So other than a T2 weighted images, what other images you have?
That is T1 images are also there, sir.
Hmm. So how does the mass looks like in a T1 image?
That is a black colored this is T1 weighted image.
Okay.
So,
Do you have DWI or stare or any other images which are important to characterize the mass in MRI?
diffusion weighted images.
It looks really away from the muscle.
It's most likely a liposarcoma arising
Mm.
between the maximus and minimus. Maximus
Or
and
Medius. These two medius are there, sir.
okay. Okay, we have less time, so we proceed further. What else did you do?
So after radiological investigation, I will go for multi-port throughput biopsy of this tumor.
Have you done that?
Yes, sir.
Report is with you?
Uh, uh, there's a high. The reports showing sir that biopsy report has a high-grade spindle cell neoplasm, sir. Actually,
Okay. So what are the differential diagnoses of spindle cell neoplasms?
sir, there are the tumors arising from the nerves, muscles, fibrous tissue, so many things, sir, which included spindle cell neoplasm, included benign and malignant both, sir. From
So,
nerve, it is a,
so if it is a spindle cell neoplasm, which IHC panel will you run? What are the things that are you going to see in IHC?
sir, for if I think about the soft tissue mass, sir, the Desmin, Vimentin, S100, uh, this all are seen to characterize the sarcomas. Sorry, sir, ISC I have not completely read. Only the,
Beta, you are presenting a soft tissue sarcoma.
this
So in this, your biopsy either would have been a small round cell tumor or a spindle cell tumor.
one.
You have to go and further characterize it. Okay, so did you get the IHC done in this patient or not?
No, sir, I have to go for surgery, sir.
You directly went for surgery.
Yes, sir.
So what is the rationale for going for surgery?
It will not because there is a clear planes are clear and there is no neurovascular involvement. Uh, will go for directly surgery with a 1 centimeter margin because the ISC will not change the plan of management for in this case, sir.
Are you sure? Read your biopsy again.
High grade spindle cell neoplasm, sir.
What does a neoplasm mean?
It will neoplasm is benign or malignant both, sir, but it is considered a
So,
high grade. So it
so
is
your
mainly
management for a benign and a malignant will not change.
slightly changed, sir.
So you don't want to know whether it is malignant or not.
Yes, sir. I want to know because the size is also 10 centimeters, sir.
So if it is malignant, what is the stage?
If it is a malignant, considering sarcoma, this is T2, N0, M0, G3. That is the stage 3
You
B.
don't have a G. Oh, yes, as high grade. Okay.
High grade tumor, sir.
G3. Okay.
G3, sir. So it's
So it is
considered
stage
stage
3.
3B. 3B. Yes.
Stage 3B.
Yes.
So now in a 3B, you want to go and excise with a 1 centimeter margin.
Yes, sir.
That's all.
And if followed by if it is come as a malignant, sir. So it is considered then post-operative adjuvant radiation should be required, sir.
What about new adjuvant radiation? Preoperative RT.
Yes, sir. In a high-grade tumor, if the size is 5 to 10 centimeter and the subtype is uh, myxoid liposarcoma or rhabdomyosarcoma or synovial sarcoma, then neoadjuvant therapy has a role, sir.
But then you didn't try to characterize your tumor.
Yes, sir.
And you are saying that the management will not change. And now you are saying that management will change by the character of the tumor. Let's
Because
see. Let's see what is your next slide. What is your plan after this? Let's see.
my plan for this case is first go for a neoadjuvant therapy, then surgery, and then if then surgery, and after that we'll plan for adult RT, sir.
Kishan, you are again going wrong. Your plan should be to do an IHC, characterize the tumor,
Sir,
and
after
then
surgery,
plan accordingly. So in this case, if this is the investigations that you have, you should
sir.
say my plan is to go for IHC,
Yes, sir.
characterize the tumor, and so if the situation demands a new adjuvant, I'll give a new adjuvant RT. If the situation demands a direct excision, I'll do a direct excision. If the situation demands a direct excision followed by post-op RT, I'll give a post-op RT. Okay. And
Yes,
if my distance from the neurovascular bundle is not very great, if I do not
yes,
have a 1 centimeter margin on my neurovascular bundle, or if I am close to my neurovascular bundle, then what else you can do?
sir. Uh, then then post-operative RT should be given, sir. If there is a high chance of
You can give a intraoperative RT
intraoperative
or a brachytherapy.
brachytherapy. Brachytherapy also can be given, sir.
You can also give a brachytherapy. So it will all depend upon your characterization of the tumor. So in a soft tissue sarcoma, you should not plan your treatment until and unless you have characterized the tumor.